Good afternoon, all. This is Adam Myers, co-director of the Health and the Public Interest Program with Dr. Adrian Fu Berman, who is also with us today. And we're happy to bring you this last seminar of the semester, believe it or not. It's going to be given by Matt Kavanagh, who will be introduced momentarily by June Padera. I just want to remind everybody that the Health and the Public Interest Program is a master's at Georgetown University. We'll have the URL and contact information in the chat, and we welcome people to look at our website, find out about our program if you're interested. We have information sessions from time to time that you're welcome at as well. So the seminar is going to take about 45 minutes with lots of time for Q&A at the end of it. The moderator today, June, is going to give a quick introduction of Dr. Kavanagh,
Wait a moment.
and then he will answer questions and participate in discussion afterwards, moderated all by June, first inviting students to give their questions, and then the broader audience. I'm gratified to see a robust audience today for Matt, and I'll turn it over to June at this point.
Thank you so much, Dr. Myers. So I'm thrilled to introduce Dr. Kavanagh today. Dr. Kavanagh is a political scientist working at the intersection of law, political economy, and global health, exploring how international and national governance institutions function and how they produce inequality, particularly in pandemics. He is the director of Georgetown University Center for Global Health, Policy and Politics, which is a cross-campus collaboration between the Georgetown Law Center and the School of Health. He is also Associate Professor of Global Health and Visiting Professor of Law and directs the United Nations Georgetown Collaborating Center on Inequality, Policy, AIDS, and Pandemics. Dr. Kavanagh has served in a range of roles inside and outside academia, including at the United Nations and as head of policy for several NGOs in the US and Southern Africa. He has been a visiting researcher at the South African Institute for Advanced Constitutional Human Rights and International Law, the University of Johannesburg, and the University of the West Indies Law Faculty at Cave Hill, and has led research projects in South Africa, Haiti, Malawi, Lesotho, India, and Thailand. Funding for his work has come from the Ford Foundation, National Science Foundation, USAID, US State Department, World Health Organization, Open Society Foundations, Robert Wood Johnson Foundation, and others. He has served on various scientific and technical advisory boards for UNAIDS and the World Health Organization, and on the Council of the American Political Science Association Health Politics and Policy section. He has presented his research and analysis before the G20 Ministers of Health, various United Nations bodies, members of the U.S. Senate Foreign Relations Committee and House Ways and Means Committee, European Parliament, and South African Department of Trade and Industry. A fun fact about Dr. Kavanagh is that he is a scuba instructor in his spare time. We are absolutely thrilled to have you with us today, Dr. Kavanagh.
I'm so glad to be here. So thanks very much for the invitation and for having me here. So I'm gonna talk for a bit and try not to bore everybody to death via a Zoom conversation. So but I do have a few slides that I'll show you, and by few I mean 40, but that's okay. But what we're gonna talk about mostly here is to try to think about how social determinants drive not just kind of health outcomes in the United States, but health outcomes around the world, and also about kind of what might be possible to do about that. So as June was saying, I am a political scientist, but I'm also somebody that's come from having worked for many years in a couple of different sectors. So I kind of cut my teeth as an activist in kind of civil society spaces, and so I worked for several decades with NGOs and activist organizations on access to HIV medicines and on a variety of different different pieces in the US and in Southern Africa. And then I've also worked at the UN in trying to move things there. And of course at Georgetown and a couple other universities. And so I kind of bring a mix of these different experiences. And so happy to talk as we go, both about kind of what is true in the world, but also given the nature of this fantastic program, how the change making that we have seen over the years has or has not worked, and what some of the kind of strategies have been to kind of improve things overall. So let me go ahead and dive into kind of where we're gonna start, and we're kind of gonna talk writ large about this idea of global social determinants of health, and I'm especially gonna focus in on pandemics. But let me just start with kind of the basic fact, right? So if you are born in the world, where you are born has massive influence over how many years you're going to spend on the earth, right? And so, in the wealthiest countries in the world, in the countries with the highest life expectancy, you can expect to spend on average 85, 86, 87 years on the planet. That's on average, right? That's across in a national population. But if you are born in Nigeria, you should, on average, expect to spend 54 years on this planet. That's a 40-year difference, right? It's an entire lifetime of difference based on kind of where you are born, how you are born, and in what context. And so that gives us a context in which we're talking about the differences in people's life expectancy and what drives it. This is here in the United States, right? And you will note that the United States is not on the left figure, right? It is not among the countries with the highest income, highest life expectancies in the world, which is pretty remarkable because the United States, of course, is the richest country in the world. It's the most powerful country in the world. And yet we have, on average, a growing gap between what our peer countries, right? So countries like Japan, like Sweden, like the UK even, like Canada, Australia, Germany, countries that are wealthy countries, the United States overall has a lower life expectancy than all of those countries. And it's growing, right? And so what this image shows you is that, in 1980, that gap was there, but wasn't that massive. And it grew over time to be a 2.2 year gap by 2000. But now we're looking at a massive gap of 4.1 years between average countries of our similar income and the United States. And if you look, of course, in 2020 and 2021, we saw a massive decline in life expectancy because of COVID-19. But note that on average, countries in other contexts actually didn't see as big of a gap, a big of a dip, right? We saw a much bigger dip in COVID-19 than similar countries. And so that tells us a little bit about what's going on in the world. And it tells us that money doesn't buy everything, of course. And so what I'm going to talk about is this idea of the social determinants. And that is a primary way in which what we are looking at. Now, I'm going to talk about both kind of social determinants and medical care. But what social determinants are is this idea that actually the major impacts that we're seeing often on people's life, on their well-being, on their quality of life, come not from differences in medical care, come not from the choices that they make, whether they make healthy choices or not, but instead come from the context in which people are born, live, work, and eventually die. And so that's everything from housing and transportation to the education and the job opportunities that people have, to also access to nutritious foods, discrimination, violence, the environment in which people live, and even the language in which they are able to work and live. So that, people who don't have access to grocery stores don't have the access to healthy nutrition, and that has long-term health implications for them. Regardless, it's not about choices that they're making. And so we see this mirrored at a global level. And in fact, this is a kind of conceptual framework. I'm not going to dwell on it too much, but the core of it says, right, that there is a social position that people are born into globally, that affects their material circumstances in which they live. And that, yes, that interacts with the healthcare system, but it is primarily this social position and material circumstances that determine the distribution worldwide of health outcomes. The World Health Organization has put together a social determinants report chaired by somebody named Michael Marmot, who we've worked with a bunch in our center. And what that report found was that there are actions that can be taken to address the social determinants of health and close the kinds of gaps that we see. That improving the conditions of life is an action that can happen around the world, and that it's deeply tied up in tackling the inequitable distribution of power, money, and resources, right? That we're not just talking about a situation where health outcomes are a medical question, but instead they're a social question, but they're also a political question. So our center is the Center for Health, Global Health Policy and Politics, right? We believe deeply that looking at power is one of the best ways to understand what we're going to see in terms of health distribution, but also what we can do in terms of affecting that health distribution. The issue that we're talking about, though, is not just about deprivation. It's not just that the poor do poorly. It's actually that often inequality is a driver of health outcomes. And so what I'm going to talk about for the rest of this conversation here is really a focus on this inequality. That it is true that overall, people living in poverty do less well, and I'll show you some slides that show that worldwide. But it is also true that more unequal contexts are actually bad for your health. And we can see that most especially when it comes to pandemics. And so we just released 2 weeks ago, our center, along with a bunch of colleagues around the world, put together this report for the Global Council on Inequality, AIDS, and Pandemics that we started. And what it found is that pandemics are inevitable in certain ways, but that what's really inevitable is outbreaks. But that inequality worldwide is actually causing there to be more pandemics, that's causing there to be longer pandemics, and it's causing outbreaks to become pandemics. And so what we looked at was to understand how is this interrelationship between increasing inequality and pandemics related. The overall argument of the paper and the report that we put together is, as I said, that there's this inequality pandemic cycle. That inequality between countries and inequality within countries causes there to be pandemics, that outbreaks are more likely, and that when outbreaks happen, they are likely to be bigger. We're less likely to be able to stop them because inequality undermines effective pandemic response. And so those pandemics are longer, they're deadlier, they're more economically disruptive. But it's a cycle, right? The argument here is that not only does that happen, not only does the rising inequality we see around the world help explain why we're seeing more and more pandemics, along with, of course, more travel, more globalization, more trade, but that the rising inequality we see is actually causing those pandemics. Well, not only is that true, but it's also true that pandemics cause more inequality. And so we have this cycle in which we are locked into right now, rising inequality causing pandemics, pandemics causing rising inequality, and on and on and on. And so I want to give you a little bit of information about that. So here's some of the research that we did for this report, and I will try not to spend too much time on graphs and point estimates. But here's, on your left, what you see is a kind of set of analyses that we did with a bunch of colleagues that shows that countries with higher inequality have seen higher COVID mortality, right? More people died per capita in countries with higher inequality, higher rates of HIV infection, and also higher rates of AIDS mortality than their more equal peers. That unequal contexts do less well in pandemics. And you can see that in the United States, that states, this is the kind of middle graph here, states with higher income inequality had higher mortality rates. In Brazil, this is your third graph here. In Brazil, if you kind of break it down based on education level, which is a good proxy for income level, right? What we saw is that those with the least education, illiterate populations in Brazil, had a double the rate of COVID mortality. And this is kind of context in which we understand the ways in which these inequality pieces are actually driving pandemics. Here's another set of graphs. So we also did an analysis looking at HIV in cities. And what we found is, not shockingly, right, that overall in almost every country in Africa, there is higher prevalence of HIV in slum dwelling, among slum dwellers, right? Which is a pejorative term, but it's also a term, a specific term, right? In kind of in geography of the UN, informal settlements, people living in crowded, overcrowded housing in low income settings have higher HIV prevalence in almost every country. This shouldn't shock us, right? This kind of multi-dimensional inequalities that exist is really important. But it's also really interesting that a handful of countries have actually turned it around. That actually what we see is that in Senegal and more recently in Namibia, there's actually almost no difference between slum dwellers and the rest of the urban population. And that in some countries like Lesotho and Zimbabwe, you actually see that slum dwellers have lower rates of HIV than the rest of the population. And so that's really interesting, because part of what it tells us is that you can mount responses that are inequality sensitive, that we're talking about, right? That if you pay attention to inequality in pandemics, you might actually be able to reduce the inequality that's actually kind of we see. And it's not an accident that Lesotho and Zimbabwe and Namibia and Senegal are among the countries that are doing the best in the fight against HIV right now. And they've done it by actually responding to inequality rather than ignoring inequality. And so if there is this inequality pandemic cycle, the argument here is that it can be disrupted and we can take action against it. This is not a hopeless cause. The argument is not that you will not have the ability to improve people's health and well-being until we have an entirely just world. We can actually take actions that will interrupt the pandemic cycle. So we looked at 4 different areas, right? We looked at the social determinants of pandemics that I'm going to talk about in just a second. We also looked at the ways in which kind of the failure to mobilize communities actually has driven some of the pandemic problems that we've got. And then we looked globally. We looked at the global financial architecture and the architecture through which science, the best medicines, actually reach populations around the world, and found that those 4 areas have very clear examples of where you can see this cycle happening, but also where you can act to disrupt it. So let me start with the social determinants. So not surprisingly, it is the case that disadvantaged populations do less well in the middle of a pandemic. So that we see a strong association between socioeconomic position and pandemic outcomes. You can see that in HIV, you can see that in COVID-19, you can see that in rich countries, you can see that in middle income countries, you can see that in poor countries, right? And so lower household wealth in Brazil, the income gradient in Sweden, all matter. We also see that it's not just about income, right? It's multidimensional. And so racism is strongly associated with negative impacts in the pandemic. So that if you adjust HIV rates for age, what you see is that the distribution on HIV in the United States is strongly skewed against Black populations. That Black populations in the United States face much higher rates of HIV than do white populations. We also see that white individuals have twice the odds of being virally suppressed, of achieving good medical outcomes. And so racism comes into and intersects across the populations. That migrants, people in prisons, gay men and other men who have sex with men, transgender women, sex workers, all of these folks have faced challenges not just on HIV, but also on COVID-19. And so what other pieces do we see when it comes to the social determinants? We see that inequalities in living conditions are one of the best predictors of health outcomes writ large and health outcomes in a pandemic. So for example, living in overcrowded homes, we can see this in England and we can see it in Zimbabwe. That in fact, during COVID-19, one of the best predictors of poor health outcomes was, do you live in overcrowded housing? And so we often kind of, in the middle of the pandemic, what did we roll out? We rolled out vaccines, we rolled out testing. But very few countries tried to address the housing conditions that people were living in. And those were among the most clear clear determinants of who lived and who died. What job you had in COVID around the world mattered. Having an informal job, precarious unemployment, unable to work from home, those were directly associated with poor health outcomes in the middle of COVID-19. That health workers, essential workers, and the unemployed, whether you're looking in London or West Africa, you see that there's a very clear situation of certain populations and certain employers making you vulnerable, far more than whether or not you had health insurance. And of course, inequalities in access to healthcare also mattered, right? And so as we look kind of writ large at HIV, what you can see is that levels of education in most countries, right, are associated with whether or not you've ever had an HIV test. But interestingly, look at Eswatini. In Eswatini, they've actually reversed it, right? So again, it's possible to do this. Tiny country in Southern Africa managed to achieve higher rates of testing among those with no education than among those with secondary education. And that's a reversal that you see almost nowhere in the world, but it shows that these gradients that I'm talking about are not inherent. You can see the same thing in the United States when it comes to pre-exposure prophylaxis, for example, right? And here we're back on race, right? And what we can see is that the coverage of people who need pre-exposure HIV prophylaxis in the United States, if you are a white person, it's likely more than half that you have accessed that PrEP if you need it. But if you were populations of people of color in the United States, much less so. Here's COVID, again, looking at that same kind of question when it comes to those pieces. Food insecurity, similarly, right? What we see is that low food security was true largely is directly associated, not just with bad outcomes on nutrition, but on chronic health, on physical conditions, but also on mental health. And so again, these social determinants are driving people's health outcomes. All right, so that's at the individual level. I want to talk then for a little bit about the global level. Right? So we know that inequality drives pandemics and is at least associated with it in a variety of ways. One of the things we know is that where populations are themselves, and this is what we saw previously, are themselves vulnerable and have lower health outcomes, where the social determinants are problematic, what we've seen is that that makes populations vulnerable to outbreaks and creates the conditions in which those outbreaks happen. And I'll talk a little bit about the mechanisms we found. But this is also true at a global level. And so one of the things we know is that during COVID-19, high-income countries around the world surged financing to address COVID-19. On average, countries spent 8% of their gross domestic product responding to COVID-19 among high-income countries. But low-income countries had almost no money to be able to do that. Low-income countries spent 2% of their GDP on responding to COVID-19. That is everything from buying vaccines and getting them to people, to getting PPE to people, but also to things like allowing people to stay home from work, right? Giving people money so that they could get childcare. Those kinds of responses that happened in high-income countries didn't happen in many parts of the global South. And the reason is that over the last decade, a mix of policy and debt has actually shrunk what we call fiscal space, meaning that there just isn't money in countries to be able to invest in responding to pandemics. And so right now, if we look around the world, developing countries are living under $3 trillion in debt. Now that is money that was borrowed from on the kind of global market, some of it from the United States, some of it from China, some of it from the International Monetary Fund and the World Bank. But countries, when they have a shortage of payments, much as we talk about debt in the United States, which is hugely high, low-income countries, middle-income countries also borrowed. And they had to borrow even more in the middle of COVID-19. And so now we are looking at the highest level of external debt in years. And what that means is that countries are choosing, governments are choosing day in and day out whether or not to pay for education, pay for healthcare, pay for employment support, pay for all of those things that I talked about in terms of the things that are driving pandemics in terms of social determinants, housing, all of those things, and paying back the debt. And that in fact, in about 60% in African countries, for example, 60% of all the taxes raised is never being used by government to respond. It's going right out the door to debt payments, 60%. That among developing countries, more than half now spend more on repaying debt than they do on education and health combined. And so this is making the world more vulnerable to pandemics, because countries that can't address the social determinants of health are more vulnerable to pandemics, but also governments that are not able to respond when outbreaks happen are in trouble. And so, for example, one of the things that's happening is that in the global south, increasingly, you see fewer and fewer doctors, but even more, fewer and fewer nurses per capita. And that is the result of insufficient fiscal space. All right, final point I want to make here is really about access to medicines. That when it comes, I've been talking about the social determinants and then talking at the global level, the between country inequalities on funding. But it is also true that medicines needed, whether that's antiretrovirals to fight HIV, whether that's vaccines to prevent COVID-19, are hugely unequal between countries. And so this is a map 1 year after the COVID-19 vaccine became available about what portion of the population had received at least one vaccine in the world. And so what you see is that in Europe and in North America, most of the population was able to receive a vaccine. Now, there's all sorts of complicating factors to this. There's vaccine hesitancy, there's all sorts of other things. But 1 year in, that was very little of what's going on here. What's really going on here is that low and middle income countries, just even when they had money to spend, were unable to get access to the vaccines going around the world. And if you look at, especially at Africa, but also you can look at India, you can look at Thailand, you can look at kind of a variety of countries in the region, Bangladesh, what you see is that the countries with less money had less access to vaccines. They weren't able to buy them on the global market even when they had money. Now, this is an interesting experiment because, there was a moment when the world came together and actually pooled a lot of money to be able to buy COVID vaccines. So it's not just about the point that I was making before, right? Which is low-income countries don't have access to money. That is also true, and that undermined things. But this is not the result of money. This is the result of a system in which the decision-making over whose orders for vaccines were filled were decided not by governments, not by the World Health Organization, not by the United Nations, but by companies and CEOs of companies. And so those companies shipped vaccines, of course, to high-income countries where they are based and did not ship them to Africa, even when they had money to buy them. Now, this is not just unjust. It's also terribly bad for global efforts to stop pandemics, because you can't stop a pandemic in one country and not stop it in the other countries, right? And in fact, if you look at the studies that have been done, you can look at the Omicron variant, right? Many of you will remember with trauma, right? The moment when Omicron came and the moment when Delta variant came and various other variants that came to the United States and ticked up COVID cases here in the United States and in Europe. Those came because there was low vaccination levels in other parts of the world. One of them, for example, rose in a moment when India had 2% coverage of vaccines, while the United States had 70% coverage of vaccines. If you use vaccines, if you're stopping some transmission, if you're stopping kind of the vulnerability, that prevents the kind of dangerous variants that happen around the world. And so it's very clear that not only are there more cases when you don't vaccinate the world equally, but there's also variants that spread around the world. And so the whole world was made more vulnerable and pandemics more likely because we didn't distribute vaccines equitably. And this is not just a COVID situation. So this is HIV. And what we've seen in HIV is that when new medicines are created, it takes about a decade for them to get to the African continent en masse, which is amazing because obviously the majority of HIV in the world is in the African continent. And so, you know, the rates of HIV being 10, 20, 30 times higher in countries on the continent, and yet the new medicines that happen take about 10 years to get there. When it takes 10 years to reach the people most in need, what we know is that HIV spreads around the world. And so the continued existence of the HIV virus is not unrelated, right, to the global inability to stop it. And in fact, what we know is that people on HIV treatment don't spread HIV. They can't transmit if it's effective. And we've got pre-exposure prophylaxis that stops HIV from spreading. And so this question of how quickly can you get access, how many people will die, is deeply tied to how quickly you can act. Right now, we have long-acting HIV medicines like lenacapavir and a few others that have come to fruition and mean, for example, 2 shots a year with a 95+% opportunity to stop the HIV virus. Those medicines are available in the United States. The first doses just arrived in 2 African countries now, despite the fact they've been available. So we're doing better. It's not been 10 years. It's only been a year, but we're still seeing this kind of limitation. Now look, we have in the early HIV pandemic, what we saw was that 12 million people on the African continent died without access to HIV treatment from the time it was made available in the United States to the time that it finally scaled up in the African continent. Now, that did not, eventually, there was the ability to make generic AIDS drugs, and we made them around the world. And eventually, the price of those AIDS medicines dropped from $20,000 per patient per year, which is completely unaffordable, down to now it's $40 a year. It turns out it only costs $40 to actually make the medicines. The rest of the cost is in other costs by drug companies. And so if you just focus on making them, even if you focus on making them with a little profit, you can do it. And so how do we get there? Eventually what happened was not that drug companies lowered prices, was not that governments around the world decided to take action. It's that activists around the world actually gathered and put pressure both on governments and on drug companies to create a big pool of money and to allow factories in Africa, Asia, and Latin America to make those AIDS medicines rather than restricting it only to companies in the United States. And so we know that not only are inequalities deadly, not only are inequalities driving pandemics, but inequalities can be fought by social movements that are effective. And today, almost all of the people in the world have access to HIV treatment who immediately need it. There's a few million that need access, but the prevention piece is still a huge problem. All right, my final points here are what can we do about it? So one piece is we also see, I should say this next few slides are just to show you that I've been talking about the ways that inequality drives pandemics, but here what I'm talking about is the fact that pandemics increase inequality. And so we see that, for example, right, during COVID-19, we saw people pushed into poverty worldwide. In the European Union, child poverty increased. Extreme poverty around the world are still now well above what they were pre-pandemic eras. And in numerous countries, wages have fallen rather than increased. That HIV has done similar things, right? Decreased productivity, undermined economic growth. Part of the challenge for many African countries has been the bite out of global growth out of growth of GDP and well-being of the national fiscus taken from the HIV pandemic. And in fact, what we see when we do analysis of data on the International Monetary Fund is that every year after a pandemic, inequality of income actually increases between people. And it peaks about 5 years later. So that my colleague Michael Marmot, when we were launching this report, he said, in this kind of amazing way, he said, look, the rich had a very good pandemic. And that is true, right? That actually what you saw is that income inequality grew during COVID-19 because some folks were able to stay home, some companies were able to make billions, while many people were not able to do so. And that creates the cycle that we're talking about. All right, I'm going to talk then about kind of how do we address the inequality that we're talking about. This is not meant to be a hopeless story, right? That the inequality that exists in the world can be interrupted at its root, and we can take actions on pandemics that actually take into account the inequality we have, take into account the world as it is, and try to drive actions that undermine it. And so 4 solutions are what we came up with, right? And so let me just walk you through kind of how these might work. So one is we can interrupt the international economic inequalities, right? High levels of debt, low revenue collection mean that many countries aren't able to address the social determinants and the medical determinants of pandemics. And then when pandemics hit, they don't have any capacity to surge. They can't roll out funding to their population. They lack the capacity to stop pandemics when they happen. And so what can we do? We actually have the ability worldwide to do kind of 2 core things. One is the debt that's held around the world is a public health issue. It's a public health crisis, and that we can reform that debt. Down the road from all of us, right, is the International Monetary Fund and the World Bank. They have a huge role that they could play in actually dropping the debt that exists. And secondly, we could design a facility so that actually worldwide, your ability to respond in a pandemic isn't dependent on how big your GDP is. And so we could create structures within the IMF that surge money to countries that need it in the middle of a pandemic. Second thing we could do, we can address those social determinants of pandemics. So here, the argument is that here's the mechanism through which it works, right? Inequality in power and money creates big determinants in education and housing that make populations more vulnerable. They make populations less resilient. And that inequality actually undermines the ability of countries to respond to those, to pandemics. That when outbreaks hit, some populations are able to do things like stay home. And so here's a story. Singapore, one of the richest countries on average per capita in the world. City-state, surrounded mostly by water. When COVID hit, they had a remarkable set of advantages. In Singapore, they were able to mount a really effective response. They reduced the number of cases. They did an incredible job at responding through traditional medical means. But what they didn't do was to pay attention to inequality. And so in the middle of COVID-19, what happened is that they discovered in the middle of the outbreak, or in the middle of the pandemic, after having done such good work, that migrant workers in Singapore, the people who were serving the food, the people who were cleaning the houses, the people who were living as a kind of subservient class within Singapore, those migrant workers had a massive COVID outbreak happening among them. They had never been tested. Singaporeans living in well-off situations, which is much of the country, had done very well, had had regular testing, had had access to things, but the migrant workers had almost none. And so what Singapore ended up with was a big outbreak in Singapore because they had ignored the inequalities that existed. And so the answer here is, of course, that you can address those inequalities, right? That we can think about using tools like education, tools like jobs, tools like other pieces to actually make countries more prepared. And one of the things you could do is you can have a situation where in a pandemic, you surge what's called globally social protection, right? And so every country in the world should have the ability when an outbreak happens to help people do things like stay home. You know, in country after country, the poorest people ended up making a decision. I would love to stay home. I would love to prevent the transmission of COVID. I would love to be able to do that, but I have to go out and work because if I don't work, there's no food on the table. And choosing between letting your family starve and losing your house or getting infected with COVID, well, there's no real choice there, right? People made the choices that they needed to, and that meant that everybody was more vulnerable. And so if you have a pool of money where you can surge to say that in a pandemic, help people stay home, give people the social protection that they need, help them to deal with being unemployed, that can have a huge impact. And we see in the research that it's possible. Okay, third, what else can we do? We can speed access to pandemic technologies. That where technologies are controlled, where we have amazing science, right? So mRNA vaccines. I hate to break it to you, friends, in the United States, but vaccines still work, right? Despite what our health secretary seems to think. And not only do vaccines work, but mRNA vaccines are remarkable, right? They are a remarkable technological breakthrough. But do you know why it didn't stop the pandemic? It didn't stop the pandemic because people didn't have access to them, because the prices were high and the supply was low. And so what we should be doing is we should be having factories around the world ready, able and capable to make the vaccines that we need, the medicines we need, and we could do that. But we need two things to be able to do that. One, there's a set of international rules around intellectual property that mean that patents on medicines make it so that factories in other countries can't make those medicines. And so we can waive that. There's nothing, patents were not handed down from God. They were not actually kind of, inspired by divine beings. They were created by international law. And so international law could say during a pandemic, when there's a pandemic, the current pandemic of AIDS, the future pandemics that we are looking at, you could actually just waive intellectual property rules. And that would allow the production of medicines around the world. And that would prevent the spread of viruses. That would prevent the rise of variants and resistance. And it would make all of us more safe. And finally, the other piece that's hugely important and will resonate with what you all do really closely, I think, is that we know that many communities are poorly served by standard public medical services and health interventions, right? Whether that is marginalized populations who are migrants in the United States, whether that is marginalized populations who are LGBT people in Uganda, what we know is that community-based organizations can often reach those people who are unreached by the standard and mainstream health services. And so what we've seen overall, and we actually have some empirical evidence that shows this, is that countries that invested in what we call community-based infrastructure, right? Those community organizations that can do outreach work to the communities that are not reached. Where that investment happened, they did better during COVID. They've done better during AIDS. They did better in responding to Mpox. And so what we know is that breaking this inequality pandemic cycle is possible, and community-based organizations are a key piece of it. I'm going to end on this photo from last week, not to brag. I like to brag sometimes, but mostly it's to hopefully say that you should be in the HAPI program. You should be thinking about how are you going to be advocates for changing these things. You can be and you should be. So this is a picture from last week, where 2 weeks ago, where we were able to actually kind of pull together a set of people who thought about these things writ large, who created the thinking that's behind this pandemic. And then we were able to get it to the president of South Africa, who is chairing the G20 group of countries right now. And so the biggest, most powerful economies in the world gathered their health ministers 2 weeks ago, and we were able to present the findings of this report, and several of them are taking it up right now. Not because we were lucky, but because we worked for 2 years to build a political strategy so that we could not only say things that would resonate with people, but get them into the hands of the people who might have the ability to do so, like President Ramaphosa. And so we were able to do that here. And so I leave you with just an idea that even these kind of big, giant global problems have solutions, and there are kind of political mechanisms through which we can get those solutions to the people who can act. Thanks very much, and happy to have a further chat from here. Thanks.
Thank you so much, Dr. Kavanagh. That was a really, really incredible talk, and like a really, really great way to kind of finish off our semester with this seminar. So I'm now going to take questions from the audience. We're going to start off with my classmates, with my peers. And then if we have no further questions and we have a little bit more time, we'll move on to any questions from the audience. And you can either raise your hand in the raise your hand Zoom feature, or you can put them in the chat, and I'll be monitoring that as well. So it looks like we have a couple questions from my classmates. We're going to start with Taruni.
Hi, Dr. Kavanagh. Thank you so much for your talk. A few of us are in a global health systems and policy class, so I think a lot of the topics you covered are things that we've been kind of learning about through the semester. So my question is, I know you outlined some solutions of what we can do next. Which one of these do you think is the most politically feasible, and the one that would have a bigger impact on reducing inequality for these future pandemics? And then also in general, what would help these regions with their public health infrastructures, even outside of a pandemic scheme?
Super interesting question. So I think they're all politically feasible, and in part, that's why we came up with them, right? Now, behind all of them is a bigger picture. And so if you can go to, it's called inequalitycouncil.org. So you can go to inequalitycouncil.org and you can kind of download the whole report. And what we did in the report is we said, look, there are big changes that need to happen. Some of them are not politically feasible, right now. But for each one of these areas, we tried to carve out something that we thought was politically feasible. So, let me give you a few examples. So on social determinants, right? Well, okay, what do you need to do for social determinants? You need to ensure good education, good jobs, fair housing, the end of racism, right? So, okay, those are pretty good goals, but I'm not clear that that's going to happen in the short term, right? But what can you do? Well, one of the things we saw is that in Brazil, there is this brilliant program called Bolsa Familia. And Bolsa Familia, right, folks may have studied this, et cetera, is just a cash transfer program, right? And it's a cash transfer program to families in need. And one of the things we found is that Bolsa Familia was one of the most effective tools, far more effective than testing, far more effective than social distancing in certain ways, at actually enabling effective pandemic response. It's worked against AIDS and it worked against COVID-19. And so countries could enact a set of cash transfers. Those are very politically feasible. They work. There's good evidence for them, and they're relatively affordable. And so we think that's possible. And then they certainly should have one so that in a pandemic, they're ready to go immediately, right? Surge money to the people, because telling people just stay home while they can't feed their families is ridiculous, right? So obviously, right? So have those kinds of programs so that you can do those kinds of movements. On a kind of other scale, access to medicines, right? And so, my colleague on this thing, and I say colleague mostly like my hero, right? He is far more famous and important than I am, but Joe Stiglitz, right, has had this idea for a while, which is you could replace patents on medicines with prizes. So that instead of, we need to incentivize research and development. We don't want to destroy the scientific enterprise by removing the incentive to do studies to make the next medicines. But do you have to give a global monopoly as the result of, figuring out a new medicine? Maybe not. So maybe in COVID, instead of saying, let's give a patent to the people who invented, who created, they didn't even really invent, who developed the vaccines, right? Instead of giving them a patent that's worldwide, 20 years long, and a full monopoly, what if instead we just gave them $5 billion? Just boom, well done. Do we really think that anybody in the world is going to say, well, I only got $5 billion, so really there's no incentive for research and development anymore, right? Of course not, right? So let's give prizes, but then you take the intellectual property and you can make those medicines around the world. Now, as of now, that is not politically feasible. Sorry to say that. It's a great idea. He should do it. But what is politically feasible is that you could say every time the World Health Organization declares a pandemic, we should waive intellectual property rules just on pandemic goods. Right? And so high-income countries, the United States would still have patents, right? There would still be a patent on it in the United States. But in South Africa, if they wanted to waive that patent right, they could. There wouldn't be a global rule against it. That's the kind of thing that I think is politically feasible. And I think we've got to take action on all of the multiple different fronts to be able to enact those. But I love your question because I do think that this political feasibility is so crucial for people in public health to have, right? Because you can come up with the very best policy analysis ever. I teach a policy analysis course, right? So here's an advertisement. Come take my policy analysis course. You should take it. It's fun. And when we go through things, one of the things we always start with is, how do we understand what is and is not politically feasible? Because if you go to your boss and you say, hey, I've done a great policy analysis, here's the policy I think we should adopt, and your boss looks at it and goes, that's never going to happen, you've just wasted a lot of time, right? And so thinking about what is possible right now is really, really important, even as we're visionary for what should come.
All right, thank you so much.
Oh, yeah. Sorry. The next hand up on my screen is Haley.
Thank you also again, Dr. Kavanagh. That was such an informative talk. So I just had a quick question. Two of us are also in a different public policy for scientists course. And we were speaking about how this administration is potentially going to start removing funds from PEPFAR. And I was just wondering what your thoughts are on how that's probably going to continue the inequities that most, like the HIV pandemic has like perpetuated, and how removing those funds are going to continue to perpetuate that, and what you would think a possible solution would be in order to keep those funds allocated towards PEPFAR.
Yeah. No, I mean it's incredibly disturbing. It's incredibly devastating. The United States is the richest country in the world. We actually don't do a whole lot when it comes to aid, right? And so I think often it gets kind of imagined that somehow the United States has historically been very very generous. And that's just not the case, right? So it's not 1% of the budget. It's less than 0.1% of the budget goes to these programs, right? So this is a tiny amount of money, and yet it's done an incredible amount of good, right? And so, I think many of us that work on HIV or TB or malaria are really, really worried about what we're going to see kind of coming, right? This is a move that absolutely makes the world less secure. One of the things that we saw during COVID is that some of the countries in Africa actually did far better than countries in other regions, because the people who were experts in infectious disease were coming out of the AIDS response, right? And so you saw many African countries with the world's best virologists, not the world's worst, right? The world's best virologists, plus community-led infrastructure that was able to go and reach people to do testing, right? That's PEPFAR. That's PEPFAR funding, right? So, I'm of two minds. On the one hand, I'm not a huge fan of the aid model. I think aid overall as a structure tends to be too colonial and too structured around decisions made in Washington, D.C. on behalf of other people. And that's not a great model for how you kind of, run the world. And so in an ideal world, we would be doing things more like the Global Fund to fight AIDS, TB, and malaria, where there's a big pot of money, countries that need access put together their own plans, and then we apply in that way. But that said, I think it is ridiculous that the United States is thinking about kind of cutting this funding. Now, are there things to do? There really are, right? So here's an interesting fact. The United States said, we are ending the PEPFAR program. And then people around the country said, oh, no, you're not. And there were protests, and there was lobbying that happened, and there were, religious leaders that weighed in. And all of a sudden, the Secretary of State had to go to Capitol Hill and say, oh, no, just kidding. We are not ending the PEPFAR program. We are just changing the PEPFAR program into something different, right? And yes, we're going to spend money on it. We are. And so, what we've seen is that over the last 2 years, advocacy has absolutely worked, right? That going to Capitol Hill and lobbying has informed members of Congress about what's going on, and they've actually defended the program. That actually there have been protests, right, that have actually been quite effective. So I think there's a ton that people can do, and I would encourage you to do it, because I think this is, we are the richest country in the world. We have an obligation to help support and address the kind of fiscal space questions that I was asking, and PEPFAR is one of the ways to do that.
Thank you.
Perfect. Thank you so much. Next up, we have Noah.
Thank you so much for such an incredible talk. My question has to do with the one of the on the last slide that you had that talked about the ways that in a pandemic there's a lot of focus on like medical solutions and instead not like the focus on social determinants and the environmental determinants of health that people struggle with during a pandemic. However, something that came to mind for me was the frontline workers that are addressing those determinants, and how they may be struggling with those same determinants themselves. So I'm curious to know what you think or how you think that global health and pandemic response organizations can better address those determinants of the frontline workers themselves that are dealing with those determinants as well.
I think it's a super smart question. So really, really interesting, right? And um, you know, the thing that our analysis shows is that social determinants are not just kind of bad writ large if you care about health equity. They're actually dangerous, right? They actually kind of create vulnerabilities. And that is 100% magnified by health workers in that context, right? So where health workers themselves are not paid well, what are they doing? They're working far more hours than are needed. They're working in conditions that are poor. They're not able to necessarily do the kind of education that will help them to be the very best at their jobs. They often don't have the tools of the job that they need, right? We did an analysis we also run something at our center called the Health and Care Worker Policy Lab, right? And it looked around the world at the laws that protect health workers themselves, right? And there's these big, big deficits, right? Where you've got these, especially frontline workers around the world who don't have access to social protection, right? Who are often, community health workers around the world are often the people that are at the front lines, and yet they can't, if they get unemployed, they don't have unemployment insurance often because they're considered only informal workers, right? And so what do you do if you have precarious employment? Well, you certainly don't worry if somebody says, go ahead, go in anyway, even though you don't have masks, even though you don't have protective equipment. Well, what does that do? That spreads the virus around. So this really is a kind of, a thing that hurts everybody, but especially hurts those on the front lines. And so absolutely, I think a couple of things. One of the things we've pushed for really strongly is, health worker specific social protection efforts, right? That say, all right, frontline health workers should be first in line to make sure that they have access to a package of social protection that keeps them able to do what they need, right? So that can be cash transfers to augment salaries if needed, although no health worker should be paid at what many of our health workers are paid, right? But certainly that, but also making sure that they have good sick leave for time off, right? Because one of the things we know is that health workers who have sick leave are able to actually, kind of be far better at their jobs and far less likely to spread infectious diseases, right? Two, there needs to be a guaranteed right to PPE. We ended up in the United States in a situation where you had frontline health workers who didn't have access to masks in the middle of trying to respond to COVID-19. Not only did they die, but they spread COVID-19, right, to all sorts of other people, including the most vulnerable people. In general, there's a set of, and I won't get too wonky on it, right? But OSHA has a set of regulations. They never applied them. The kind of the protection that our health workers have in that is not considered a right. It's considered this kind of structure of a like occupational safety and health issue. And as long as you don't actually center the health workers themselves, then you miss the key point of the whole thing, right? So that's our thing. You can go and there's some stuff, and I can stick some of that into the chat if you're more interested in those pieces.
Thank you so much.
Perfect. Okay, we have a couple questions in the chat. The first is from Jero, who says, thanks, Dr. Kavanagh, for this amazing presentation. And also says, you highlighted how global health systems are shaped by political and economic forces as much as medical ones. Given that, what do you see as the most realistic pathway for countries with limited resources to strengthen their own health sovereignty, rather than relying on external donors whose agendas may shift? How do we build resilience that isn't donor dependent?
Yeah, that is like the center of global health questions right now. It's super interesting. Yesterday, we did this event for what it's worth, and I'm pretty sure they recorded it with Joy Fumafi, who was the health minister of Botswana. And so we did something at the Moarta Center that was really great, and it was really interesting to hear her talk about this, right? Because in this moment of America first foreign policy, she was thinking about this as an African leader and thinking about what that looked like. And so anyway, I would recommend that as a thing. Look, I think there's two or three big things. One, many countries are now trying to figure out how to create better fiscal capacity for themselves. So, one of the things that's true is that, for example, now this is going to be random, but stay with me for a minute. International tax laws currently emphasize the idea of taxation at the home of the corporation. What does that mean? Well, it means that if you are running a company that's operating in Botswana or operating in Malawi or operating in Bangladesh, but you're based in the United States, the taxes for your company are collected in the United States. Well, okay, if instead those taxes were collected in Bangladesh or in Malawi, then that money could flow into responding to health pieces. Now, those international tax treaties don't have to be agreed to. And so one of the things countries are actually talking about is withdrawing from some of those tax treaties and changing the way that they tax companies so that we actually ensure that money stays where it needs to. Fun fact, the amount of money that leaves the African continent every year is far larger, by a factor of 6 or 7, than the total amount of aid and trade investments that come into the African continent. So on average, the African continent is actually is actually a creditor to the rest of us, to the rest of the world, right? And so part of it is actually saying that, the systems actually have to shift. And that is a central thing that has to happen. My colleague, Atia Warris, is leading a whole bunch of work on this. She's the UN Special Rapporteur on debt and human rights, and she's been trying to help countries to rewrite their tax laws. So it's really interesting to think about tax law as the thing that public health people should worry about, right? Because it's certainly not what we are taught, right? It's like, okay, let's do virology and let's do epidemiology, but how many people on this call have ever taken a class in tax law? I have not, right? But one of the things is for us to start thinking as public health people about how do we engage in this question of revenue generation. I think the second thing is that there is, in fact, the kind of ability to default on debt. And so countries are actually thinking about that because then they can start really investing their money in the kind of health systems that will work. And then third, Brazil is doing this really interesting thing. So I have been very lucky in the last few years that I've gotten to spend a lot of time in Brazil and South Africa working with government folks there. And the Brazilians are brilliant. They have created a structure that's kind of like a mix of our NIH, right, the National Institutes of Health, but also a pharmaceutical company. And so they have research and development, and then they make the drugs in Fiocruz, right? And so that is a really interesting innovation because what it means is that most of the drugs that they need, they make through a government-run facility so that those are affordable. And that kind of thing could make it possible for many countries around the world to be able to actually afford to give their populations the most important and most essential drugs. And that kind of innovation's got to happen. When you're not Brazil, which is a pretty powerful country, it's a lot harder to do that because high-income countries yell at you and they say, don't do that, and that would be terrible, and you need to keep buying them from our companies. So it takes political will. But for example, the African Union is coming together and forging an alliance to try to do it together. And that's the kind of thing that I think might make a difference.
Awesome. Thank you so much. Okay. Abad.
Hi, yes, thank you so much for speaking with us today. My question's kind of regarding I thought it was really interesting that you brought up intellectual property and maybe in a time of crisis we can maybe waive this and this can incentivize research and not another science race like how we saw with the vaccines being pushed out during the pandemic. But I guess my question, because I also thought your response to an earlier question was interesting, how you said like instead of promising a patent or something, we could like just give them like some reward instead of like a something longer than that. But so I guess my question is like if we would be implementing something like that, that would encourage like more international cooperation or like the development of like a vaccine or some technology on like an international scale, like how what would you think the funding would look like for that? Like, would that be something that WHO like has like a fund set aside for, or would that be like the host country doing that? I'm just not like, I guess I'm also not aware of existing frameworks for funding when it comes to like international contributions on healthcare, because I know like for some of it, like gain of function experiments can be like a biosecurity, like from a biosecurity standpoint, very important. So would just love to hear your perspective on that. Thanks.
No, also a great question. You all are fun. I like you. All right. So facts. The COVID-19 vaccine was developed almost entirely with public funding, right? So where did that funding come from? It came from two places. One, the bulk of the funding for mRNA research came from NIH, DARPA, a few other kind of big US federal ideas. And the this kind of big funding that was available for that absolutely resourced that. Now, that's a bit of an exception because there are lots and lots of drugs that come out that are partially funded by NIH, where NIH will fund the basic research, and then some of the translational research and some of the development costs are borne by companies in the private sector. But the heart of this, the message really is that the big innovations often could be financed publicly, right? And so, and we already do that, right? So for mRNA vaccines, so now you're going to get me on a tangent, so I'll try not to be too long on this, but mRNA vaccines, like, where did the Moderna vaccine come from, right? Who is Moderna? Had anybody ever heard of Moderna before COVID-19? No, right? I had actually, but like for a random reason, right? So Moderna was a tiny little company in Massachusetts that had made hundreds of doses of vaccines. They'd never made thousands, they'd never made millions, they'd certainly never made billions, right? And so they were this tiny little company that had this deep relationship with the NIH, right? And so the NIH developed, and NIH scientists worked with them on this, developed and supported the development of mRNA vaccine technology. But then what happened? That set of knowledge got transferred to Moderna and given to them through an arrangement. Like there was some money that came in both directions, and they then had a patent on it, right? Which meant that they had a monopoly over the production of it. The United States did not require that the US, the NIH be part of that, right? And what was Moderna's big contribution? Well, they did work. They figured out how to turn this idea into an actual vaccine, and then they built a bunch of factories. Where'd they get the money to build the factories? Oh wait, they got that also from the United States government, right? So the United States government said, we're going to buy billions of doses of this. Here's some big money to be able to do that. And what did they do? They went and they called a company named Lonza, and Lonza in Switzerland retrofitted a factory and took the technology that they had figured out, and within literally a month had figured out how to build a factory in Switzerland, another one in Singapore, another one in Massachusetts, that was able to make at scale the kinds of vaccines that they were making. So could we have done this in Brazil? Could we have done this in South Africa? Could we have done this in Thailand? Absolutely, right? No question about it. But we didn't, because Moderna had the patent. And so there's not an inherent reason why the reward for having done that work needed to come in the form of a monopoly. Usually economics says monopolies are a bad idea. And Adrian, yes, absolutely, right? So it's Dean Baker and it's Joe Stiglitz who together have been kind of thinking about this idea of prizes instead, right? Economists generally think monopolies are a terrible idea, right? But within innovation, it's the way that reward innovation. And the danger, of course, is you can't not reward innovation. Just public funding on the front end probably is not enough to fully get us to where we need to be to get the kind of cutting edge innovations we need. But so fine, pick out a bunch of the biggest, best ideas you need and promise that if somebody figures out how to create the next cancer X, Y, and Z, that they will get billions of dollars because that's what they're hoping to get. So fine, let's do that. But let's pay it for them there because actually the production of all these medicines is pretty affordable. We can actually do it pretty cheaply. And the very best folks in the world at figuring out how to do things cheaply are not in the United States. They're in India, they're in China, they're in South Africa, they're in Thailand. Like these are folks who specialize in figuring out how to do high quality production for affordable rates. So let's enable them to do that and break this connection between discovery on the one hand and production on the other. So it's very much a viable option. And in fact, you'll be interested to know a certain senator named Bernie Sanders in the United States actually introduced this as a bill that he tried to get to happen in the United States. So it's not totally pie in the sky. Not saying that Bernie Sanders has a whole lot of influence on what the United States Senate passes right now, but one could imagine it happening someday in the future.
Amazing. Thank you so much. I don't see any other questions from my classmates, but I think we maybe have time for one more question from the chat. And I'm just going to go off of the first one I see here from James Ranga, asking if there are any connections between different types of governance, capitalism, socialism, despotism, and I think implied like kind of what you were talking about in terms of like global inequalities.
Wow, I love this question even more. Okay. So this is really an interesting set of questions, and I don't know that we have a full answer, right? But a few thoughts. So one is at the heart of this question. One piece of it is about democracy. Is democracy actually good for your health? And overall, what we find is that democracy writ large is relatively good, is associated with better health outcomes, but that the outcomes are really mixed, right? It's not a kind of one-to-one relationship where democracies always do better controlling for other measures, right? It's pretty complicated, it's pretty tangential, and it's pretty contingent. In pandemics, there's another set of questions, right? And the evidence is even more mixed on kind of quite what happened, right? So Amartya Sen, famous economist, has a kind of way of thinking about this, right? And what he says is, democracy is good because it does a few things. One, it allows governments to not lie to themselves, right? Information flows in two directions. You have opposition and you have the government. And so what happens often in autocracies is that governments end up lying to themselves. And so the person at the lowest level of government has every incentive to say, there's no problem here, there's no problem here. And his analysis on this was on famines. He said, why is it that famines don't tend to happen in democracies? They tend to happen in autocracies. And the answer is because low-level government officials have every incentive to say, there's no famine, I don't know what you're talking about, right? And so what did you see during COVID-19? You did see that, right? You actually saw all the evidence kind of right now, if you look closely, is that in China, when COVID-19 broke out, I think the evidence is that there was not some giant conspiracy. There was not a kind of, there was certainly not an effort intentionally to create a bioweapon. That's not what we're talking about here. But what you do see is you see low-level government officials in China saying, absolutely, nobody talk about this, right? Punishing doctors who were spreading the information on social media, taking down those posts, trying to say, we have no problem here, we have no problem here. The evidence suggests that by the time the Beijing government actually knew about what was going on, the WHO had already heard about it, right? So that says to us that in pandemics, there is an advantage to sharing information, wide dissemination, having opposition parties, having a free press. Like that allows a flow of information that not only gets people information that they need to protect themselves, but also ensures that governments don't lie to themselves. And that's a really important kind of piece. That said, on the other hand, what you saw was a lot of messiness in democracies, right? Democracies had a harder time shutting down, things and ensuring that people followed rules. And especially free market capitalist democracies, right? That the United States, the UK had some of the hardest times in the middle of it, right? But the reason for that largely, I think, and the evidence is still kind of growing, is because of a neoliberal economic approach that's not inherent to democracy, but is more about a certain way of running economies, right? That says we're going to have market fundamentalism, and we're not going to have things like a right to health. So in South Africa, when the government tried to impose certain, public health measures, the Constitutional Court said everybody has a right to health. Of course, the government has to protect everybody. Of course, if the hospitals are overwhelmed. But in the United States, somebody said, no, 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 I want to hold a religious gathering, and this other person said, no, 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 I want to open my business. And they said, well, you have a right to religious freedom, you have a right to capitalism, but you don't have a right to health. And so therefore, the government's ability to act was really restricted. It turns out that one of the worst kind of government structures is free market economics that is kind of market fundamentalist alongside democracy that is a kind of rights-based but doesn't have a social economic rights context, i.e. the United States, right? This particular combination of things turns out that we're just not so great at responding to pandemics. And if you look, Mpox, COVID-19, HIV, over and over and over again, when pandemics hit, we have not done particularly well in the United States. So I think there's some lessons to be had, right? Other governments, Norway, brilliantly, right? Big capitalist country, very, very democratic, but actually has a really different kind of democracy. So I think it's worth looking at governance structures and understanding that, democracy is not an either or, capitalism is not an either or, socialism is not an either or. These are kind of complex systems, but when you put them together, you can definitely see that there are certain structures of government that seem to do better in responding to pandemics. And I think in the United States, we have a lot to learn from some of those that did far better.
So if people can bear with me for about 30 seconds, I want to take this opportunity to thank Matt Kavanagh for a really great seminar today, and to remind you all that we're going to be on break as far as seminars until January 21st, when we'll have Dr. Joseph Graves, one of the key people in the race and medicine field. It's going to be a great seminar to start off with, but we'll also have Dean Baker, speaking of Dean Baker, later in the semester, and Peter Mayberdick, who is going to touch on some of these same issues raised today. So please come back after January 21st, on January 21st. And with that, I'm going to turn it back to June to close this out. And thanks again, everyone, for attending this semester.
Yeah, thank you so much. Dr. Kavanagh, it was an absolute pleasure. I know that myself and all my classmates really learned a lot from even just this short time spent with you. So thank you so much for taking the time to speak with us. And yeah, we will see the rest of you next semester for more seminars. Thank you so much.
Thanks to you all.